Hello and welcome to the Nottingham and Nottinghamshire Maternity Voices Partnership Showcase Event 2022. I'm Amanda Doughty. I am the Nottingham Nottinghamshire MVP Chair. What is MVP? MVP is Maternity Voices Partnership, a team of professionals and local lay people working together to make local maternity services better. What are the aims of the MVP? We want to improve safety of maternity care, improve experience of maternity care, make sure that improvements help the most vulnerable groups the most. We do this by putting women, pregnant people and their families' experience at the centre of our work. The areas that we'd cover are Nottingham and Nottinghamshire, and we cover the Nottingham University Hospitals and the Sherwood Forest Hospitals. The members of the MVP team are the NHS staff such as midwives, doctors, managers. There are the women, birthing people and families from different backgrounds, the MVP volunteers, and members of the wider communities such as doulas, charities and other organisations such as Health Watch. An independent layperson is the interim chair, that's myself. How can you get involved? Have your say. Please go to notsmvp.co.uk/showcase 2022 and fill out the MVP Showcase Event Survey. We welcome you to submit questions for our question and answer session today and vote for priorities for the Nottingham and Nottinghamshire MVP if you are in our area. We would like to know what matters most to you: shared decision making, induction of labour, visiting arrangements or the discharge process. What you can expect from today is the experience of maternity services in Nottingham and Nottinghamshire during the COVID-19 pandemic from Hester Kapur, the Programme and Insights Manager, Health Watch Nottingham and Nottinghamshire, and Nadia Higson from the AIMS Trustee. How can you get involved in the work of the MVP? Join our team of MVP volunteers and help make local maternity services better. We offer flexible working, various volunteer roles are available, and training and support so that you feel confident in your role. Please go to notsmvp.co.uk/volunteering. You also are going to hear about the Ethnic and Minority Working Group findings from Anna Rotowska, MVP Volunteer Health Watch Nottingham and Nottinghamshire, and Binish Nasmeen, co-founder of the Association of South Asian Midwives. We'll then go for a short break, where we encourage you to go to the notsmvp.co.uk/showcase 2022 to fill out our survey. We'll then have our question and answer session with Gemma Boyd, consultant midwife from Sherwood Forest Hospital, Julia Andrews, professional midwifery advocate from Sherwood Forest Hospital, Paula Shaw, head of midwifery from Sherwood Forest Hospital, and Sharon Wallace, director of midwifery from Nottingham University Hospital. We will then give you the priority outcome from our survey at the end. Thank you very much. I now pass you over to Hez.
Good afternoon, everyone. I'm Hester, and I'm here to talk about the people of Nottingham and Nottingshire's experiences of maternity services during COVID. A disease we knew very little about, COVID, was here. Not fully understanding how contagious, deadly, or transmissible the disease was, strict guidelines were introduced nationally into maternity care. Our phones started to ring, messages arrived, and posts on social media increased. I would now like to share with you two of these experiences. The first one, I welcome Begum.
I'm Dr. Begum Tokay. I am working at the University of Nottingham, Chemical Engineering Department. I live in the UK since 2013. And before that, I lived in States in Northern Cyprus, and I'm originally from Turkey, and my big family relatives there are still there. I have two boys, Xavier and Matthew. I will talk about Matthew's birth.
When and where did you have your last baby?
6th of July 2021 at Queen's Medical Centre, Nottingham.
What were your expectations around pregnancy care during the pandemic?
I didn't have a lot of expectations in my head, but I was expecting in the sense of followed up well within the midwives, within the consultants, also the scans, because my first pregnancy, towards the end, I had to stay in hospital for 3 weeks because of the baby's positioning. Although I had an idea that it was going to happen with the second pregnancy, it was a bit difficult to convince the midwife and even the consultant for that. But towards the end, they saw that need.
What did you think giving birth would be like during the pandemic?
I think I knew that it was going to be difficult in the sense of not same as having the visitors. I already knew that, and I even didn't think how the actual birth was going to happen, in the sense of if my husband could have come and things like that.
How did COVID restrictions change your experience of having a baby?
Probably it changed my experience a bit in a worse way, because I didn't have my loved ones with me. I had not a lot of support in that sense. And I think not having consultants meetings face-to-face also maybe affected some of the plannings that they could have done before. But one thing we sort of find a bit difficult, that the midwives, they didn't exactly know what my husband needed to do if he wanted to come to the planned C-section. They said, follow this rule, but just go and check this website for the COVID tests. But it wasn't very clear, and they weren't really, I think, informed uniformly.
Is there any advice that you would give health professionals about how to support new expectant parents?
Some of my scans were not booked by the midwife, whether they forgot or not. When I went for my already planned scan, but nothing for the further weeks, the hospital midwife sort of approached me as if it was my fault that I didn't, ask for the scans and everything. I know the information at that time was changing very fast, but I think everyone should, all the midwives, whoever, they should have the information very clearly to the people. Most of the problems probably come because of the communication issues at many consultants. When I see different consultants, they were actually giving very different opinions. And then that was a bit confusing, because you expect that shouldn't be really different. But sometimes I even felt that they didn't read my notes, but what they were suggesting me implied to me that they didn't read my notes, they didn't know my age. And that was a bit scary. And also at that time, I think the progress report about maternity in Nottingham was published, and it was better, but there were still, problems. And that was a bit scary, I should say.
Thank you, Began. We're now going to show you another video. This is Emma's story.
I'm Emma. I'm 39 years old. I live in Nottingham with my husband and 3 children. I'm a type 1 diabetic and I've had that for 35 years. And I'm a childminder. So obviously I'm able to work at home and have my youngest with me all the time.
So when and where did you have your baby?
I had Amaya in May and I had her at the Nottingham City Hospital.
What were your expectations around pregnancy care during the pandemic?
It was actually, as horrible as it was actually a blessing. Being type 1 diabetic, I have to go through an awful lot of appointments, hospital visits, and obviously this time around, they were trying to be that stricter, obviously not going in as much, but I still had to be under a consultant. So it was kind of, it was a blessing, as horrible as it sounds, because even though they were able to monitor me through phone calls, and check my blood sugars. I've got like a Libra system on my arm. So it was all my blood sugars they could monitor on their computers. So it just meant that I didn't have to go into the hospital as much, which was really good.
What did you think giving birth would be like during the pandemic?
The only thing that worried me was obviously my husband being allowed in and how long he was allowed in for. So that was the only thing that I was worried about. But obviously he was able to, but the nurses and doctors kind of helped as much as they could in regards to advising. And luckily he was able to join me, but that was the only thing really that was worrying me at the time.
So what was your birth experience like?
It was fantastic.
Oh.
It really was. The only thing is probably with all the curtains, when you're in the ward, the only thing was all the curtains were closed and had to stay closed. So sometimes you found you wouldn't be able to speak to the people, like the mums next to you. So that was a bit, you were on your own sort of thing. But the experience was fantastic. The nurses were overworked, but they made sure that everyone was okay. It was really good.
Is there any advice that you would give to healthcare professionals about how to support new and expectant parents?
No, like I say, the City Hospital was absolutely fantastic. The midwives made us, myself and my husband, feel comfortable. It was, again, for my last experience, which is my last baby, it was I want to say a perfect birth. And obviously that's thanks down to obviously myself, but also to the midwives and nurses that was at City when I had her. I don't think they get enough praise.
Thank you, Emma, for that positive story. Overwhelmed by expectant mothers and partners' reaction to the guidelines, MVP and Healthwatch embarked on a project to give these people a voice. Our objective was to find out how restrictions had impacted on the whole maternity journey and make recommendations to the hospitals, CCG and nationally to NHS England of how developed questions on pregnancy, labour, birth, care in hospital and care at home. We had an overwhelming response, and in just 1 month we received 364 responses. Despite the restrictions and the pressure that maternity services were under, 65% of women said that the care they received was good or very good. However, 1 in 6 women said their care was poor or very poor. They talked about not being listened to, appointments being cancelled, and not seeing the same health professionals consistently. The main issue women had was not being able to have their partner with them during scans, good and bad news at appointments, during recovery on the ward, or on the neonatal intensive care unit. This led to women feeling isolated, lonely, anxious, and existing mental health conditions worsening in some cases. Half of women said partners' needs were not met. Many reported that partners felt left out, unable to ask questions or be involved in joint decisions about their child. We have since published this report and circulated it widely, and I'm pleased to introduce Nadia Hickson from AIMS, who shares her thoughts on this report now.
Hello everyone, my name's Nadia Hickson and I'm a volunteer for the charity AIMS. I'm also an AIMS trustee, and my volunteer roles include being a member of our campaign steering group and answering inquiries on our helpline. I'm also a user rep for my local MVP down in Kent. So thank you very much for inviting me to speak today. AIMS, if you're not familiar with it, stands for the Association for Improvements in the Maternity Services. It's a volunteer-run charity which was founded over 60 years ago, and ever since then we've campaigned tirelessly for improvements in the UK's maternity services, as well as supporting individuals directly through our helpline and sharing information to pregnant women and people and their healthcare providers and the others who support them, with our hugely informative books, journal and website resources. A few years ago, we redefined our mission as we support all maternity service users to navigate the system as it exists and campaign for a system which truly meets the needs of all. Now, I'm sure it won't surprise you that a major strand of our work over the last couple of years has related to the maternity service restrictions introduced as a result of the pandemic. So this included individual support from our helpline volunteers, keeping up-to-date information on our website, both about research on the impact of COVID on pregnancy and the latest guidance across all 4 nations of the UK, producing template letters which people could use to self-advocate to get their support needs met, and campaigning. So campaigning included lobbying to NHS England and the professional bodies, calling for changes to the guidance that we believed were needed, also responding to government consultations and using social media to raise awareness of the issues. Then in October 2020, we were instrumental in bringing together the But Not Maternity Alliance. This was named after a successful social media campaign started by the doulas at the Birth Bliss Academy. So the Alliance was a group of organisations who'd all been campaigning individually, and we realised that we could be stronger together. So as well as lobbying and issuing press releases as a group, we also maintained and published details of the current state of maternity service restrictions across the UK, so tracking how that was changing over time. And we also organised a joint webinar with National Maternity Voices. And I don't know if anybody here was at that meeting, but it was attended by over 60 MVP and MSLC reps, largely from England, but also from other parts of the UK. And that helped to raise awareness of what the national picture was, to help people share examples of best practice, but also to identify what more needed to be done at national level. And there was some further lobbying work that came out of that meeting. So the report, The Experiences of Maternity Service Users in Nottingham and Nottinghamshire During the COVID-19 Pandemic, was, I think, hugely valuable in validating the need for the measures for which the But Not Maternity Alliance was lobbying. I think it's so rare, but it is so important for the voices of maternity service users to be heard in this way. And whilst AIMS and our alliance partners were hearing very similar concerns via our helpline, actually having this level of detail with both qualitative and quantitative data provided a really powerful illustration of the impact which the restrictions were having. So thank you very much, all those involved in that initiative. It was a really helpful one. I've also been asked to speak about how AIM's work aligns with that of the MVPs. Now, hopefully I've already given you an idea of the kind of work that we do. But as a small charity, we don't have the resources to campaign locally. So it's great to have input from MVPs about what is happening in their areas. That helps us to identify national trends, and it also helps us to prioritise our support and our campaigning efforts on the issues that are most important. We also hope that our resources, which are all freely available on our website, are of use to MVP user reps. So those include birth information pages on a variety of topics, our position papers, which aim to provide concise information on key campaigns issues, and our journal articles. The journal in particular has featured a number of what we call birth activist briefings on topics which have included the role of the new regional chief midwives and who they are, the NHS England Equity and Equality Initiative, and one on the importance of getting involved in your local MVP. So if you'd like to find out more, please take a look at our website, www.aims.org.uk. And if you'd like to support us as a member, or even better, as a volunteer, do please get in touch. Thank you.
Thank you, Nadia, from all of us for your endorsement and taking the time to make this video for us today. This project has led to a number of impacts. Visiting restrictions have been adjusted as national guidance was updated throughout the pandemic. And it has informed future work. For example, our current focus on personalised care plans to help improve personalised care for pregnant women and people. MVP now, through this work, also has representation from the University of Nottingham Midwifery Department. And I have here a quote from Dr. Catherine Evans. The report highlights women's highly varied experiences of receiving care remotely, either by phone or video call. Some women appreciated the convenience of virtual appointments and felt they enabled partners to be included. Many others, however, felt remote care was impersonal or rushed and did not fully meet their needs. This has led to a funded study led by the University of Nottingham, which is now underway to consider the different ways in which remote care should or should not be used in maternity services. And now for my final slide. Oops. From Helen Silsby at University of Nottingham. The findings of the MVP report will be included as one of the sources of information, including in our review. Thank you, everyone.
Thank you, Hester. We'll now hear from Anna Ratowska, who is the former MVP project officer and now does volunteer work for us, and is a doula and co-founder of the Support ME. She'll present the findings of the MVP's Ethnic Minority Working Group.
Okay, hi everyone. Oh, it's interesting. Okay, hello everyone. A bit of background, why we did this project and why it was important for us and for people who use maternity services in Nottinghamshire. As you probably know, and newest reports and Brace reports were saying the Black, Asian and minority ethnic women have poorer outcomes than the white woman. So that's why we wanted to look into that, but in the form of review instead of just asking another questions, because we have a lot of data, so we want to move to how we can improve that. And as you know, there is some research also behind the diversity of the team that cares for pregnant women and babies during pregnancy. So we used lots of information that is already there, lots of research. So our objectives for this project was to set up a working group of staff, volunteers and service users from minority ethnic backgrounds, and we're very successful in that, and we are very proud and for the staff involvement. That was crucial for the whole project, to get to know realities of working in the on the words, reality of working in the hospitals, what is actually happening. And we reviewed national recommendations, literature reviews, systematic reviews, reports, guidelines, everything that was published in the last 10 years, plus minus, and we agreed to key recommendations for local hospitals trusts. So we took what we think in discussion with the staff members, what is missing, what is lacking, where there are gaps, and we made it into the recommendations. And that's how we came up with the whole project and the project findings. Just to highlight that we had 8 service users representatives for this project, and I think that's amazing. And 9 out of 10 was had minority ethnic background, which I think it's a great success. And before we're going to go into details about the recommendations, what we found from those reviews and guidelines and what we applied to our recommendations, I want to invite you to listen to this local mother's story about her experience.
My name is Natasha. I am mum to Zaya, who is now 7 months. I'm of mixed heritage, and Zaya was born at City Hospital in Nottingham, born in June of 2021.
How was your experience of care during your pregnancy?
My initial care in the community, so going to my community midwife, I didn't really have a great experience. I kind of felt quite fobbed off. I had concerns with my iron levels. And she says, oh no, I won't do a test until you're 25 weeks. And it turns out my iron levels were, incredibly low. I remember when I'd had low iron previously, I felt the same way. So, but she wasn't reassuring, didn't want to answer my questions, and being like a nervous first-time mum. Not a great experience in the community for the first half of my pregnancy. And I was seen by a senior midwife in the community after that, and that experience was a lot better. I felt more reassured. I didn't feel like I was a hindrance, or that I was treated as if somebody who's not educated, or I don't know. I just felt like she treated me like I was stupid, or maybe how you'd speak to somebody who English wasn't their first language. I just didn't feel didn't feel right. And I think probably as well because of the area that I live in, and the doctor's surgery that I go to is in a deprived area. I think yes. I think I was treated differently to perhaps somebody who lives in West Bridgford or something along those lines.
What was your birth experience like?
In terms of the birth, important conversation with me whilst I'm in this in the throes of giving birth. But yeah, whilst I was in labour, that wasn't the right time to be kind of like having any conversation about what's going to happen after, when that conversation could have been had 5 days before. During my birthing experience, I don't feel like COVID rules were adhered to. There wasn't any testing. My partner was an hour away. He came to the hospital, but in the meantime, they'd let somebody else in the room who wasn't my birthing partner. It was a member of my family, but it wasn't my birthing partner, and it wasn't somebody that I wanted to be there.
Is there any advice that you would give health professionals about how to support pregnant women from an ethnic minority background?
I think managing pregnant women's expectations of, the care that they're going to receive, asking them about, have they got any religious or cultural, requirements, anything along those lines, really, and just having some training and knowing what concerns that we would have. For example, I have fibroids, which women of colour are more susceptible to have than white women. And it wasn't until after I'd had the baby that I was told that actually, if you have fibroids, you're more likely to have a premature baby. And I had no idea about this.
Thank you.
So my name is Natasha. I am mum to Zaya, who is now 7 months. I'm of mixed heritage, and Zaya was born at City Hospital in Nottingham, born in June of 2021.
And what is your baby's ethnicity? And did your baby's ethnicity make a difference to the care baby received? And if so, in what way?
So baby's ethnicity, she's also of mixed heritage. My partner's black. I'm mixed race, so she's mixed. I don't think that her ethnicity did play a part in her care. I think probably because in the neonatal unit, a lot of the staff were black and mixed race as well. Whereas on the maternity wards and my antenatal experience, pretty much all of the staff were white.
What was your baby's care like after the birth?
It was as if she was just whisked away into neonatal care because they could hear some grunting. That's what they called it. And they thought that it was her breathing. So she was in neonatal care for 24 hours, for which I'm very grateful for, obviously. And then once brought up onto the ward, I just thought everybody had this transitional care worker, but apparently it's for babies that have been on neonatal unit, and they help with feeding baby and anything that mum needs help with, really. I remember waking up one morning and baby had been kind of washed and her hair had been washed and combed and stuff, and that was an experience I would have liked to have done myself had I known that there were facilities to do so. But I wasn't told that there was anything available. And I've just been using a tin foil container and cotton wool. On the whole, the paediatricians were pretty good, and they would actually come up themselves every so often. So yeah, we were in hospital for 5 days following her birth. And I think I saw a paediatrician 2 or 3 times who came to me on the ward.
Okay, so thank you very much. When we were working together on the working group and review all these recommendations and guidelines and review papers, we came up with the recommendations that are actually relevant for our local maternity systems. So first of all is prioritize families from minority ethnic groups when implementing personalized care plans, and continuity of care and antenatal education. Engage with families from ethnic minority communities when developing new services, and co-produce easy-to-read resources. Enrich maternity workforce with bilingual staff. Review current training and deliver regular interactive training, either online or in person, or culture competency, unconscious bias, or equality, diversity training for maternity staff. Liaise with universities and review the culture competency, unconscious bias, and equality and diversity training provided during the midwifery courses. And the most important, that from the time that our project was published and the recommendations were published and we made it public to everyone, we just sent it everywhere, and we had this amazing conversation with the trust, and we had some impact of this project so far, which we are very proud of. Is the MVP now has a representation from the University of Nottingham Midwifery, and Sherwood Forest Hospital Trust has planned cultural competency training for staff and will include an MVP member from outside of their own organisation as well in this training. An MVP current focus is on personalised care plans and includes a continuation of the ethnic minority working group, because we will work on this topic further. And thank you.
Thank you very much, Anna, and for all that work as well. Next, we will show you a presentation from Binesh Nazmeen. She is a midwife, a mentor, and new to midwifery education. She is passionate about addressing health inequalities and investing in improving maternity services for those who care and for those who work in them. South Asian midwives, and she also works to support marginalised midwives and raise awareness of barriers faced by diverse communities.
Hello and welcome. My name is Binesh Nazmeen. I'm a midwife who has specialist interest in equality, diversity and inclusion within maternity services. I am also a co-founder and co-director of Association of South Asian Midwives, and today I am here to speak to you about ASAM. We are a community interest company that was set up in the peak of pandemic, really. There was 3 of us midwives. We met each other in a conference and realised that as marginalised members of the midwifery workforce, there were some experiences that we had seen or been witness to in caring for our diverse ethnic communities and people from diverse ethnic heritage that were actually reoccurring. Considering there's 3 of us that are 3 generations of midwives, we're all about a decade apart, with Nafisa being around a lot longer and me being midpoint and Sundar starting very soon after. There was a concern that we recognised and realised, especially when it came to embrace and outcomes and inequality. So we actually, on our first ever meeting together, sat down and wrote a memorandum of kind of our visions that we wanted to do with ASAM, never thinking that it would progress as quickly as it did. Our first sit down was in 2019 in October. And that's when we had our 3 visions that came to light. We wanted to support our communities by sharing their experiences, by speaking directly with them, by being able to give health literacy to our communities, because we realize there's a massive kind of gap there when it comes to our migrant communities specifically. There was also a realization that as a member of the South Asian community, I recognized that there were some taboo subjects like bereavement, infertility, mental health that our communities weren't discussing as openly, and we know all of these impact maternity and maternal perinatal health quite significantly. So all three of us wanted to do that. We also wanted to raise the learning that we got from our communities and inform and educate healthcare professionals about this. So we are speaking directly with and sharing all of this information in training. And finally, we also wanted to support marginalised members of the midwifery workforce. We all recognise ourselves as Asian, South Asian, the three of us directors. However, we realise that there are many a marginalised midwife who need support in this area. So we started first with an unofficial launch when we were just going to share all of this via digital platforms. That was the plan, sharing this information on the digital platform. And that happened round about in June 2020. However, we had to soon after realise that there was a massive gap in the market. We were getting DMs upon DMs from people from our communities, as well as the marginalised workforce, saying that this is needed, it's vital, and actually we need more from you. So we registered as a community interest project, community interest company, so that we could be a not-for-profit and help our communities better. We are in the process of doing some health literacy work very soon, and we've called it, I've misspelt it there, it says chair and chat, but I suppose that's not too far off. You can take a seat on the chair and chat, but you can also have what we would like to say, chai and chat. So grab a cuppa and let's talk, so that there's peer support and there's actually health literacy conversation, especially around the subjects that we've already mentioned earlier. We've got members, our midwifery members that are based nationally that want to do this. And we also are sharing some of those experiences with consent on our social media platforms and our website. There are blogs of some of the experiences that our marginalised communities are facing when they come into maternity services. And there's more work being done in this area, which our website will be updated in very soon. We also support midwifery workforce. So we started membership at the end, mid-June for our midwifery workforce and our student midwives. We realised actually representation in the midwifery workforce is really important for two reasons. Actually, people from diverse ethnic communities can sometimes find people that look like them more approachable, and they're more likely to think or believe that they understand their barriers and access, and therefore discuss them more openly with those members. So that's really helpful in building trust and overcoming barriers. But also, the fact is that when key decisions are being made about care, if there is someone in the senior leadership level that is representative of a diverse ethnic community or is able to bring that nuanced approach, we are able to better make decisions for our communities, especially when it comes to development of services. So by supporting midwives and future midwives into midwifery, we're trying to make sure we don't lose midwives. We realise there are many issues that our midwifery workforce face. The workforce race and equality standards quite clearly highlight this, and sometimes we lose them just at the point where they are student midwives before they can even be midwives. So our membership offers career development support, pastoral support, wellbeing workshops. It helps develop their interviews and personal statement skills, and it's very much focused on how we can retain our staff, because there is a national shortage, and we want to make sure that we have midwives at all levels that are representative of our communities. Or allies are also welcome. We have a few ally members who are members to support our work. We've been doing a lot of work in lots of different areas, and this is a lot of collaborative working with different agencies. We've done educational talks on different conferences, talking about some of the issues we've already discussed when it comes to barriers and access. We've co-created a report with the Society of African Caribbean Midwives, sharing the experiences of ethnically marginalised midwives and how we can improve those. We've done research work and support for a few different areas, and we have also supported building of new services with stakeholder groups and national policy when it comes to the Home Office around domestic violence in minoritized communities. We're doing a lot of educational talks at institution levels and supporting our Royal College and our local maternity groups that are working within the workforce to make sure that we are equitable across the board in every way we can. Our most recent passion, because of the massive gap in this area, is perinatal mental health and better understanding and recognizing perinatal mental health, especially when it comes to people from diverse ethnic backgrounds. Often in the West, we get taught a very Eurocentric way of looking at mental health, which doesn't necessarily reflect how the global majority may present. So it's often mental health depression, there's no word for depression in many languages. So how does one communicate that they have something where they have no word for it in their mother tongue, or they may not speak about it at home? So this is the kind of work and training we are currently supporting at the moment, because there's a really big need for it. I'm conscious that we have a quick run through of what ASAM is, what we're doing, what we're hoping to do, and the kind of work we support. But we've only had a limited time. But if you ever want to contact us, we are available on our website, which is, if you just Google ASAM Midwives, we are the top one, and we're quite bright and colourful. You can probably tell we like a little bit of colour, and you're welcome to reach out to us from our website. Thank you so much. It's been a pleasure to speak to you, and hopefully speak to you soon. Bye.
It seems odd to say thank you to a screen because she's not here, but but thank you. We're now going to take a quick 20-minute break. If you'd all like to, if you're online, walk around a little bit at your home and pop the kettle on. We'll be back at 1:45. If you're in the room with us, please feel free to mingle and also walk around and stretch your legs. Thank you very much. We're now going to do our question and answer session, which is going to be led by Hester.
Thank you, Amanda. And thank you to everyone who sent in questions or submitted questions today. I've got a few here, and we've got about half an hour to get through these, so let's see how we get on. Are you ready, panel?
We're ready.
We're ready. I'd like to introduce Sharon Wallace from Nottingham University, Paula Shaw, Gemma Boys and Julie Andrew from Sherwood Forest Hospital Trust. And thank you for joining us and being on the panel today. So the first question is, when will there be a home birth team?
I will. No. Am I switched on? I am switched on. I can hear that. So, no, thank you very much. And I absolutely appreciate that, you know, the home birth service isn't as it should be at the minute, and that's because of our staffing. We had to make lots of changes through COVID and redeploy staff, and we couldn't offer a robust service. So at the minute, at Nottingham, for the community midwives at NUH, we're supporting women on a case-by-case basis, and that's generally between 8 a.m. and 8 p.m. when we have a community staff around. What is difficult at the minute for us to staff is the overnight. So I know that coming to the next few weeks, we've got about 16 nights when we have a home birth service. We can't predict, obviously, when women will labour and birth, but it's not where we want to be, and that has got to be our priority focus. We were aiming to relaunch our home birth service in June, but it's fair to say I think we've been impacted greatly by even more sickness, and so it's how we can do that safely. So what we've done, or what the community managers and teams are doing, is to they've identified staff who are really keen to lead a home birth service. So at the minute, it's everybody who works in community is expected to participate in that service. So actually, to get that real good buy-in commitment to providing a service, it's got to be done by people who are passionate about home birth, and I absolutely was one of those once upon a time when I was a proper midwife. So we want to absolutely harness that enthusiasm and get it right, and we're looking at putting the team on the one of the birth centres at City, and to go out from there, because again it's a resource, and it's having people there and our staff there that might not need to be needed every night of the year, but there will be help in other parts of the service. But if we have a really good, robust home birth service offer, then we will see the numbers increase, and that's where we really want to be. And I'm absolutely an advocate for home birth. I think we should be doing that and offering that more and more for women. So I'm going to hand over to my colleague.
Yeah, so we're very much at Sherwood the same as Sharon are in Nottingham. So we've had the challenges around the pandemic and our staffing, and it has been very difficult, and I agree the service is not where we want it to be. We're planning to relaunch June, July time, but we've had struggles around sickness. We have got recruitment, and we have successfully recruited into positions at Sherwood, but it's about ensuring the staff that are trained and they've got that suitable experience out in community. So we are looking at a really robust package of training prior to launching that home birth service. We are aiming at the beginning of Q3 this year, so September time, to look at re-implementing. We do offer, it is a limited home birth service, and again, much as Sharon, I'm an advocate for home birth, being a mum that's birthed at both hospital and home. Personally, I absolutely 100% support home birth services, so we need to make sure it's right and it's safe for both staff and women. So yes, we're hoping to go for with a big launch, and obviously we're working in line with Sharon just to make sure that there's that equity across our system as well. So that's where we're at with home birth, I think. Yeah.
Thank you both for your responses there. And now on to my next question, which has come from a woman living in Nottingham City. How are you addressing racism by staff?
Thank you. It's a really important question, and something that we strive to do. And we have a midwife in our trust who has a social enterprise, pretty much like the last speaker, who is supporting the BME work that needs to happen. And there's two parts to that. So there's firstly around how we train staff to look through a different lens. So it's my experiences as a white working class woman, but actually we need to reflect the diversity for all of our cultures. So part of the work that we're doing at NUH is that I have a team of midwives from BME backgrounds, and they provide that insight into, is our information reflective of our population? So we know that some of our posters that are around about in the unit don't reflect that. And so we've asked for comms to redo our posters so it does reflect the diversity of the population that we serve. And the second part of that is around our training, so that again we're looking at it through a different lens as well, and we're appreciating that it isn't the same experience for all women. And so that our guidelines as well, our clinical guidelines, again, the first thing is that I will be going to them as my resource, my group, and saying, can you look at this to make sure that we have absolutely covered and reflect every woman, every service user that comes to NUH. And the second part is around how we support women from a BME background in terms of a lot of the things that we're the MVP project found out around antenatal education, continuity of carer, and again how we build that into the centre of everything we do, that golden thread for all of our services. So we absolutely are more cognizant of it, and it really saddens me that we had to get to several maternal death reports to actually say, oh, there is an issue here. And that is really shameful, I think, for, not NUH, but for the whole of the health services across the board, that it just took a lot of time. And actually, I think COVID has really brought that to the fore as well. So we need to learn from everything in COVID, recognising that there are groups of women that we serve that are at higher risk, and we need to do something different for them. Yeah.
Thank you, Sharon. And now from Sherwood Forest Hospital Trust.
Thank you. I just wanted to, I think we highlighted it in the previous presentation from Anna, that we are really invested and engaged in this at Sherwood Forest, and recognise that it's an issue that we need to tackle. We have a very different demographic than they do in Nottingham, so we have less than 5% of our population would be identified as being from a Black or Asian background. So that means that in terms of the things that potentially we might like from the recommendations there around building continuity of carer teams that focus on women from Black and Asian backgrounds. That's number one, not feasible for us in terms of our locality. And also it's about understanding what women would want and whether that's something that they would want, and why we're really keen to engage and hear women's voices in understanding and co-produce with us any services that we are building. But what we're really focusing on is our training and our starting with self and starting with our staff. Because we know from the Embrace report around the risk to women from diverse backgrounds, and what we also know that isn't because Black and Asian women are physiologically different. There is a massive element of that is around systemic racism, and it is about the way we listen and the way we hear and the way we speak, and that's absolutely in all of our control every single day with every single thing that we do with women, and we need to start working with that and starting with ourselves, and part of that journey is understanding it. So we've got 2 days from Assam coming to us to facilitate that 2-day training. We've also got continued funding to do train the trainer, so we will then be able to deliver that within our service. What we're really keen to do, coming to that training, I've got 5 consultants, an anaesthetist, support workers, midwives, midwife managers, student midwives, service users, so I'm really keen that we're doing that. Our plan is to then start integrating that into all of our mandatory training, so it's not a separate subject over here. We talk about it all the time, and then what I'm hoping is what I've got is 24 people who feel empowered and brave enough to continue that challenge and continue that role modelling. And because we're quite a small hospital, actually I'm hoping with that support of the fact that we've got such strong support from our LMNS, from our chief nurse, from our head of midwifery around this being really important to us. So I really would like, in terms of this question, to feel reassured that we're working together to address this, and it's not something that is going to go under the carpet. This is absolutely a priority.
Thank you. Very comprehensive reply.
I think just that it isn't tolerated. So those kind of behaviours, the culture is something that we're taking really seriously. Anyway, it's the thing that takes the longest probably to change. But any behaviours, attitudes is just not tolerated and is being addressed. And the other thing I think was really interesting in Anna's presentation about bilingual staff. And that probably is something that we would really struggle to do, but we rely on interpreters. We have a great service with interpreters. And we recognise that sometimes in very difficult situations, interpreters are coming in, especially around bereavement. So what I want to do and what I did at another trust is that we offer training for interpreters. So they had time to understand the different processes and the terminology and actually walk through those experiences for women and families, so that they did have some understanding, and that really helped support families. And that's something that we're going to look at doing at NUH as well.
Thank you. Thank you again, Sharon. Okay, now on to our next question. Another one from a Nottingham City resident. Improvements are required for postnatal stage care in hospital. How will you improve this experience for women? Short staffing issues are also a major hindrance to providing adequate care and support.
Thank you. Yep, absolutely it is. And so what we've done is, there's several things that we're doing. So we've introduced nurses, registered nurses, to support the maternity teams, especially on the wards. And they're invaluable in terms of a lot of the things they can do around drug, medicine rounds and caring for women post-caesarean section. So that really has helped, and it's a really positive move for us. There's certainly more that we can do around our support workers, and I think it was Natasha that talked around the experience of having the transitional care support workers, but there's more we can do with our non-registered staff as well, and looking at our staffing ratios 2-4 on postnatal areas. So we are undertaking a workforce review to see, if we, where we need to move staff and support better. So absolutely take that postnatal care has always been, we call it as the Cinderella service. And that's been a phrase that I think all the way through my 30 years in midwifery, it's been referred to as that. And it's something that we've not got right yet. And it has been particularly challenging. I mean, how we manage it on a day-to-day basis, we've reduced our bed capacity at Nottingham, so that helps us to provide appropriate staffing. We work really collaboratively with our neonatal services, but there's more to do around information and just that, what the expectations for women when they come to the ward, just the simple things about here's the toilets, this is where the food is, that kind of thing, that welcome and support. And I think there's also more we can do in terms of not relying on the medical staff for discharging women. So midwifery-led discharges is something that a lot of units do, something that I'm used to and something that I think we can do at NUH to get women back home a lot quicker than they are. I think they're hanging around for medicines. We've also introduced technicians onto the wards, so to help with those medicines to take home, so it's speeding up that process. But I think the answer, because there is a national shortage of midwives, is looking at others to provide that support for midwives and for women and families too. I don't know if
Thank you. Sherwood Forest.
Hi. So as Sharon said, at Sherwood Forest, we are also recognise that postnatal care is an area which it does provide an area of complaints from families. We regularly review our Friends and Family Test results, which is a survey that families can take while they're in hospital. And when we look at those themes that come from the Friends and Family Test, postnatal care is high up there. So we have a couple of ways that we are addressing this at the moment. Firstly, we have a maternity parent voice representative, and she is invaluable to us and to the families on the ward at the time. So she will regularly walk around the postnatal area. She will take feedback directly from mums on the ward, so parent to parent. She will engage with the parents, and she will bring those themes back, and we do look at those themes and identify where we can make changes. We have, I think both of our trusts have a shared governance council, and shared governance is a platform where the staff actually doing the work on the shop floor, they are in the best place to identify where changes need to be made and then implement those changes. So we're supporting at the moment a project with the postnatal ward core team, and that's looking at things around speeding up the discharge process. Again, the discharge is where a lot of our complaints are generated. So as Sharon said, just the hanging around waiting for the discharge chat from the midwives, waiting for medications in order to go home. So, we are really looking at how to speed that up and how to make improvements. And as I say, we are really listening to women and birthing people and their partners, and really taking those themes back and acting on those themes, which is really important.
Just to finish off, I think, the COVID work that Health Watch has done and the MVP is really valuable. and it's fair to say we've missed partners too. We've massively missed partners being part of maternity services, and it's come from, you know, national teams. And I think, you know, when we reflect back, was it done correctly? I think that's something that will happen external to us. But, you know, now as we're opening up a bit more, it's time to think about actually having partners in for longer. You know, a shout out to Small Steps, Big Change for supporting us with having lovely recliner chairs across maternity services. So if we're having partners in and we want them to support mums, their partners and their babies, then they need to have somewhere that is fairly comfortable to rest as well, and that will go a big way as well. So you know, we don't underestimate that the impact that not having partners has on postnatal care as well. So you know, the sooner we can get back to that, then the better.
Can I just have one very brief? Yeah, that's my speciality. No, I just wanted to quickly add on from just what Julia had said about our Parents' Voices champion and how we act on what she says. When we say we act on it, we escalate it to the ward leaders, to our heads of midwifery, but also she attends our bi-monthly, our maternity safety champion. So that is board level with our chief nurse and our non-exec director. So those themes are not just being, I hear what you said. They are being escalated at the highest level and taken really, really seriously. So I just wanted to make sure that we were aware that what we were actually.
Thank you. Thank you. And now the next question is from Gedling. I understand community midwives are under pressure due to low staffing levels. But what is going to be done to improve care right now?
That is a really tough one. So again, we keep coming back to COVID, and it just feels we need to move beyond that. But certainly during COVID, things changed massively in terms of those face-to-face appointments. And actually, we do a lot of care outside of inside GP surgeries, so that impacted the availability of space. We know that we haven't got enough community midwives, and again, that role that we have with the support workers is really vital. And again, you know, Small Steps, Big Change. We're doing a project with them in the 4 most deprived wards in Nottingham to increase support worker support in terms of the more social and public health messages for women and birthing people and their partners. We are undertaking a workforce review, and that will give us the number and really give us that ability to focus. But I know that we've got midwives not in the right place as well. So we need to have a really good look at how we work as community midwives as well. So you know, I suppose time and motion is probably a bit of an old-fashioned phrase, but to really understand how we're working as community midwives and what the needs of women are. So having that option for some home visits, but actually reinstating postnatal clinics if that's what women want and it's easy for them to do. So just having that range, and we still are very much within the traditional models of care, and we know that actually women want to have booking appointments at 8 o'clock at night. So if we can get the facilities to do that, then that's actually what we need to be offering, so that we make it more about what the women need and want, rather than how we're tied to a building and their opening hours. That isn't how we need to work anymore. I think the really crucial part, which will enable a lot of this, is going to have a digital health record. So from November, both Sherwood Forest and Nottingham, when a woman comes to book with a community midwife, that it will all be digital. So they'll have no paper. Women will be able to access it on their devices and iPads and computers and all sorts of things, but it will be seamless. So again, what we hear from women is that they keep having to say the same story over and over again. I think, again, reflecting back on what Natasha said about her experiences with the consultants, it will massively reduce that as well. So that in real time we'll be able to see a woman's journey, and that will help. And it will also help to identify and unlock our services a lot more than they are now. So to move away from the traditional models of community midwives working 9 to 5, actually for the staff that's not necessarily the best thing for their work-life balance as well. So it's always a conundrum, and yeah, something that we're always working on as well. I don't know if you want to say anything about your community services. Yours are fabulous, aren't they? But I have to say, my teams are fabulous as well, but we just need better systems.
No, just to echo really what Sharon's saying. So I think whilst absolutely COVID's been devastating and it's been unpredictable, it's been a very hard time, we have taken some positives out there. So we moved to more hub style working, and it's evaluated really well. Our women really appreciated being able to have an appointment time, come to Central Hub, and it's about how do we develop those. So we're working with our Parents' Voice rep, and obviously we work with the MPP as well to look at what do our women want. Let's start redesigning our services. So very much like Sharon says, we're looking at our staff and staffing models, because yes, again, we are still very traditional, and we need to reflect and move forward and listen to what our women are saying. So yeah, we're at a very similar position, and I think let's harness that energy whilst we're doing it. So yeah.
My dream has always been to have a bus so that we can drive it around to where women are and park it somewhere and have antenatal clinics in a bus. Not maybe as far as birthing in a bus, but you never know. But actually, I want to shop. So, I've asked someone to actually look at, can we have a shop not in the Victoria Centre, but somewhere like Hyson Green that has midwives in there. It's hours, we can open 7 days a week. And we can pull, like today we've got 65 antenatal clinics. That's just madness. And there'll be little bits of, it won't be significant numbers of women. It'll be 1 or 2. And it's a logistical nightmare, and it's inefficient. But if we had a shop somewhere, and actually we're looking at an old police station somewhere else in the county to have as our own, so that we can, again, open 7 days a week and really have our services wrapped around women rather than when it dictates what time a building opens and shut, and that again will be a massive enabler. But we, I've had community midwives working out of supermarkets and mosques and all of those community venues that we need to just get out of that mind frame that it's midwifery services. It needs to be in a health building. It doesn't need to be in a health building. It can be in the back of a bus if that's what we want to do.
Great responses, thank you. We look forward to that. Now our next question has come from Mansfield. Do you have a shared decision-making policy as stipulated in NICE guidelines?
Thank you. Yes, we do. It goes by a different name. It's called Facilitating Choice, and shared decision-making is really important to every single midwife. And when I hear things like Natasha's story on her birth story, all of us are midwives, and that does make us sad that something as simple as not having what she wanted and needed during her birth, it does make us as midwives, uncomfortable as well as sad. So my role as a midwifery advocate is to support women and birthing people to be heard and to have their choices listened to, and to support those choices, whether they are, quite unusual choices. And importantly, to support staff, maternity staff and midwives, to empower those staff to support the choices of the women. So, the women do have the birth experience they want. And what goes alongside that is personalised care. And again, that is really important to us across both trusts, is to have that personalised care. And we know that, personalised care really works best when you see the same midwife regularly, when you have continuity of carer, and we do recognise that. And absolutely, yes, we do work to those guidelines set out by NICE about shared decision making, and midwives really do want women to have the birth experience that they want and they need. And our community midwives are very proactive in supporting choice, and if there's something that they are not sure about, that perhaps needs somebody else to have a chat with the mum and her birth partner, then us as midwifery advocates, our role is to support those choices and to ensure women do have their choices heard, and then once they get to the unit, to have those choices acted upon as well by the staff, which is really important. So yes, we do have a policy, and we are in the process of rewriting it, and we are inviting contributions from our obstetric consultants. So we have the medical input into it as well. We are also asking our maternity parent voice representative to have a look at it from the parents' perspective, and to invite contributions from our service users as well, which is obviously how we make those decisions in partnership with parents. Anyone want to add to that?
I agree.
Okay, a few more questions. I've been told we've got 8 minutes left, so let's see if we can get through these ones. Question from Gedling. How do you propose on making communication better with community midwives? The voice service is not sustainable, and expectant mothers cannot just answer calls when we decide we get a call back when we have working lives. The 24/7 line is good, except when we're told by community midwife will be in touch, which can be a week later. It's a catch-22 situation.
Yeah, I think it's not just maternity services. It's an issue for, if anyone's rung GPs, I think we all share that same frustration. The maternity advice line at Nottingham is 24 hours a day. It's been evaluated really, really well. But there are always times, peak times, and we've got the data to see when our peak times for calls is, so that we can ensure that's staff better. But going back to community midwives, we're moving away from what used to happen is the community midwives used to give their working mobile numbers to women, but of course if they were off sick or on holiday, it was then bounced to somebody else, and so it wasn't a robust system. So again, we're looking at how we can centralise that and kind of remove the midwife from that, and have an administrator that again will be responsible for contacting women for those things that doesn't need a midwife for, and just making that more robust. So absolutely acknowledge that, and it's something that we're working on. I think again the maternity advice line has been an absolute wonder, and for any woman who has any anxieties or concerns or questions, they can ring that 24 hours a day.
Yeah, no, ours is much the same. So we do have that advice line service, and agree it is difficult, but again, looking at the hub working and the different working hours, I think that will be an extension, and hopefully that we move away from this 9 to 5, Monday to Friday. This is when advice is available, and wait over the weekend, and you've got that 24 hours emergency number. And I think it's difficult when somebody says it's an emergency, because you might think, well, it's not what I'm not ringing about. It might not be an emergency, but we need to make sure we get that better communication out, and it's something we'll work with Amanda with, because we are a 24/7 service, and we are here to hear everybody. So, yeah.
Thank you. Thank you. Okay, the next question came from the room. The induction rate appears to be quite high. What plans are there to reduce induction rates?
Yes, and it's something that we monitor, and there is guidance, and it feels like year on year we get more national guidance or evidence about offering induction, so it is rising exponentially as we get more information and women's choices as well. But it does create us challenges around having that urgent care, so women that come in spontaneous labour, to manage it with an elective or a choice service as well. So we are auditing it at the minute to make sure that our inductions are done within the guidance, the national guidance, and not done as individual clinicians' decisions or choices, because there are always risks, benefits to absolutely everything we do. And the crucial part is that women understand the benefits, the risks, so they can make those informed decisions and choices. So whatever we do, whatever process, procedure, anything that's happening, it's only ever a recommendation, and the choice has got to be with the woman, the birthing person and her partner, to be able to make that informed choice and decision with the data to say, actually, if you do this, your risk is this, and understanding what actually risk means or chances of. as well. But I think it is rising nationally. We have peers across, I have a network of fellow directors and heads of midwifery, and it's a constant ask from other units around their inductions and can we take any of their inductions because they've got X number. So it is something I think we'll see an increase in. For us, it's making sure that we audit and are assured that it's within guidance. I don't know if any of you, do you anything else you want to say?
Yeah, so our induction rate has remained fairly static. We've not seen the peak. However, we are very conscious that nationally this is peaking. There is a national working group as well as a regional working group that we are part of as a system. So we are working towards that. And it is just like Sharon says, it's that alignment of making sure that we're within national guidance, but equally what our women want, and they understand that choice that's been offered to them. And again, that's why we have this wraparound service that Julia provides. So yes, it is. It's a national increase, and it's high on the national agenda. Obviously, it's cascaded down from Jackie Dunkley-Bent, so it's been an ask from us, and we are aware of it. We'll work together as a system to ensure that we keep it front and centre.
One of the things we do at Sherwood Forest Hospitals, though, is we do have a weekly multidisciplinary team meeting around our inductions. So our process is that if an induction is requested by a woman or by an obstetrician, they fill out those details and it is discussed as an MDT so that we are able to prioritise women appropriately, but also be able to follow up with those women if actually as a group we've discussed it and we need to understand more deeply the reasons for that, and we're happy to go out and follow up and have those conversations. So it's not just like anyone that asks for an induction just gets one without that conversation and that broader MDT approach. And we have been approached quite a lot as a consultant midwife from other consultant midwives wanting to come and see us and adapt that model because it is seen as gold standard care in terms of induction.
The other thing is around, I'm really pleased that one of the priorities that the MVP have put out today is around induction of labour, and I think that probably leads us into how we work with the MVP. I'm going to steal your thunder there because I saw Nadine.
Our last question. How do you intend to improve working through the MVP? Thank you, Sharon.
And that is absolutely crucial, that we have that relationship and that support, that critical friendship to really drive our services, because we are here for women, birthing people and families. That's the reason we do what we do. And if it isn't right, then we need to know about it and work collaboratively. And so co-production for me is absolutely key to that. And that isn't just about, here's a leaflet, can you read it and does it look all right to you? It's actually about, we want to have a shop, we want to have a bus. And actually, what do you think about that? How can we do that? And we're going to do a 24-hour something or other. What do you think? How would that impact? And getting the women's views. So, again, what is women's views and experiences of induction of labour, and how can we make that better? Because, it's not our baby, it's not our pregnancy, it's yours. And you do it, a couple of times, max really for most women. In their lives, and it's such a massive life experience that we have to get it right, and so hearing that voice is absolutely fundamental to everything we do, and I'm really pleased. The MVP have done some great work, and I think we just continue to build on that, and recognising that we're all partners. No one's got there's no hierarchy. No one's got a more of a higher position or more influence. Actually, the influence has got to be with our families and not us as a provider.
Thank you.
Yeah, agree, absolutely. And for me, so I'm feeling, I keep saying I'm feeling new into my role. I can still say, I'm sure, 6 months in. But it's about building those relationships, and it's that re-establishment of relationships, because it has changed. And we were saying on the way up this morning how nice it is to be back face-to-face with people, because I've never met Amanda face-to-face. This is our first time today. So I've only met on Teams virtually. So I think it's about us re-establishing, and then obviously this needs to filter out into our communities that we serve, because it's, like Sharon says, the women and their families are front and centre at everything that we do. So it's, for me, that's my priority. It's about, let's get those relationships rebuilt, and let's get going.
All I was going to say is if there are mums and families in the room or people listening at home that are not currently in the MVP but are really interested in volunteering, I'd really, really encourage you to get involved, because I think you can see demonstrating that we're all fairly got a lot on, but we're really present to be here. We're really engaged. We're desperate to hear the voice of women, and work with you. So I want you to. I hope that what this conversation has left you with feeling is how keen we are to work with you. So if there are any people out there who are thinking of becoming a volunteer, I'd really encourage you to get involved.
I just wanted to add to about how we are actually listening to the voices of families, and of course it's easy to engage with the families when they're with us on our premises. So we are shortly to announce some listening clinics, which we're taking to every area of our geographical region that we can think of, in every community that we can reach, just to give that platform for women and their families to have their voices heard, because we know it's often, we need to hear the voices that don't shout the loudest, and that's our focus for the rest of this year as well, is those listening clinics.
Thank you. A sincere thanks to the whole panel, to Sharon, Paula, Gemma and Julie for being here today and really showing your commitment to the Maternity Voices Partnership. It is very, very well appreciated. And thank you to all those people out there who, in the room and at home, submitted their questions and made this question and answer session what it was. Thank you.
Thank you very much. I will now update you on the survey results that I mentioned at the moment, and I'm really hoping if I press this button, they will come up on this screen. And they have. Brilliant. I didn't want to press the button all day. So as you can all clearly see, the one that did win was shared decision making, and this is the one we'll be taking to our MVP meetings and concentrating on, because it is clearly very, very important to all the families that are out there. And I couldn't agree more, to be honest, although I was fully happy with either four that won, if I'm perfectly honest with you. Also, I'd just like to do a shout out today, because I think it's highly appropriate, that it is apparently Student Midwife Celebration Day. So I think that's just worth mentioning there. And well, yeah, we can. Oh, there we go. We had a nice slide for that I've now shown you all. I'm hoping, here we are, we're doing well. It is just a thank you. Thank you to everybody that is here, from the maternity staff who were supported and joined today's event, the speakers and the presentations, the MVP partner organisations, community partner organisations who came in person or online, Support for Survivors charity and the Support Me as well, and all the local people and families and MVP volunteers, either that joined us in the room or that was able to join us online as well. A really big thank you to Health Watch, Nottingham Nottinghamshire for coordinating today's event, and Nottingham Audio Visual for making this event a hybrid one and a seamless one as well. So thank you very, very much. And thank you everybody for joining us for the Nottingham Nottinghamshire Showcase 2022 event. That's all from us.